Good afternoon, everybody. My name is Susan Barber, and I'm the Community Education Manager at Mission Hospice and Home Care. And for those of you that are not familiar with us, we are a smallish, not-for-profit, and non-affiliated hospice program. And non-affiliated means we're not part of a large hospital system or a healthcare system. We actually, most of us live and work in San Mateo County or the counties surrounding San Mateo and northern Santa Clara, where we serve patients. And we've been serving our community for over 40 years now, and we were founded back in the late 70s by two women, one of whom was diagnosed with cancer and did not want to die in a hospital. Though her doctor did not tell her that was her fate, she knew that was her fate. And she was connected with another woman in our community, Helen Legrand, who the two of them knew pretty much everybody in our community, and they were able to assemble an incredible group of medical professionals that all volunteered their time, as many hospices did in those days. And Mac Nash, who was our first patient as well as our founder, and she died in 1979. The other woman that was our co-founder died in 2014, watching hundreds of families in our community being supported by the good work she did. She was 103 years old. So we're very grateful to those folks that founded us in the spirit of serving our community at end of life and providing an educational component to that work so that people have resources and know where to go, and can start to think about these things long before they are on their deathbed, which I highly recommend to everybody. So without much more ado, I'm just so grateful today to have both Ladybird Morgan and BJ Miller with us. And I'm going to bring them into the conversation now. I'm going to spotlight them both. I had hoped to spotlight them both. There we go. And BJ, when you turn on your camera, there you go. Thank you so much. And just by way of introduction, though, I think for some of you, you may have seen both BJ and Ladybird speak today. So BJ's practiced and taught in all major settings, in home, hospital, clinics, and in residential care facilities. In his work, he draws upon his personal experiences with disability and his undergraduate studies in art history as much as his medical education. BJ speaks internationally on the themes of living well in the face of illness and death. He's been profiled in the New York Times. He's been interviewed by Oprah, by Tim Ferriss and Krista Tipper, and he's authored a beautiful book. He's a co-author of A Beginner's Guide to the End. He is a doctor in internal medicine and hospice and palliative care. And Ladybird Morgan is both a registered nurse and a clinical social worker. She's been a healer and an educator, particularly in the end-of-life space for more than 20 years. She's also the co-founder and the executive director of the Humane Prison Hospice Project. And that's Chin. I want to just disclose that I also work with the Humane Prison Hospice Project, which is one of my great joys in life. And that work is to implement end-of-life care in prisons by supporting training and training prisoners to be caregivers and educating prison personnel about how to do these things. Ladybird's worked with many organizations, including the Zen Hospice Project, Hospice by the Bay, Doctors Without Borders, Commonweal, and the Mary Center's Last Acts of Kindness program at UCSF. She holds space for families and caregivers, medical practitioners, as well as directors of programs and institutions around the world to find their clearest voice as they step across significant thresholds in aging, life, and death. So thank you both so very much for joining us. And this afternoon, our title is Mettle Health, which is the name of the organization that BJ and Ladybird founded. And I've just kind of been talking about this space that we're in right now in end-of-life care and hospice and home care. I'm wondering if the two of you might just let us know why you have both devoted your lives to spending time in this space, to supporting other people that are trying to navigate this. And I think just starting there would be enlightening for many. Thank you so much. And Ladybird, BJ, whoever
Yeah.
wants.
Thank you, Susan. I was going to cut to you, Lady Bird, trying to be polite for a change. You want me to go? Okay. Well, thank you, Susan. Hi, Lady Bird. Hi, everybody. I think there's some people I know in this audience, so I'm blowing you extra kisses. So yeah, for me, I went into medicine as a way to try to make sense of my own experiences as a patient. And having grown up with a disabled mother and been in a kind of caregiver role much of my life, and then becoming disabled myself, and my own sort of dance with death and the whole healthcare um, shooting match. So I got into medicine thinking this would be a way for me to use my experiences. Um, and I, deep into medical school, as happens, I think I got disillusioned and was going to drop out. Actually, the you guys all know. I mean, the ideals we bring into sort of clinical education and training often don't last by once you kind of go through the grinder of what it takes to practice medicine, et cetera. And sure enough, I was on the chopping block myself. But I stumbled into palliative care essentially on an elective, and in an hour, within an hour or two, I was re-inspired and decided to stick with medicine. And so I went into palliative care specifically because of it being something of an antidote to the healthcare system's ills, and a way potentially to kind of reorient all of healthcare to some what I would consider a better way forward. A lot to say about that, but the general interest for me was simply I realized I was very interested in what do humans do when they bump up against things they can't change. Whereas the rest of healthcare, I think so much I didn't like about it was all about fixing you and doing things that we're pushing where we can change, um, and objectifying people. Here's a field in palliative care that was wholly embraced subjectivity, the individual experience, and stuck with people whether or not, irrespective of their curability or their fixability. That really lit up for me as someone who's not curable, who's not fixable. Um, and that combined with just the idea that we know that this kind of work, there's more need for this kind of work than there are people providing it. And so it was also interesting for me to join a force that was growing, that was on ascent. Um, so there are other things that fold into that into this work as well, but that's kind of what got me going. Um, so I'll leave it at that for now. Over to you, LB.
I love hearing that again, BJ. It's an interesting question because it feels like I've been in this field for so long now. It's hard to always piece together the earlier reasons, but when I graduated from high school, I went to West Africa and was in a clinic where I was able to work with people who were dying they were dying a lot of adolescents and pediatrics. And I was very young. I wasn't trained as a nurse or as a social worker at that point, but I noticed in myself that I wasn't moving away from it, that I wasn't afraid. I had a lot of questions. I wasn't sure exactly what to do or what was happening, but there was something sort of pulling me in that direction. And I initially went into school to be a midwife, and ended up ditching that for dance and anthropology, and went a completely different path for quite a while, into social work school and finally to nursing. But no matter what, there was always this thread that would keep bringing me back to this conversation around end of life. And mostly, I think, because it's very vibrant, it's very alive, and there's a moving quality to it that keeps me on my own toes. It keeps me awake and alert to who I am as a human, and how I'm engaging as a human being on the planet. And that to me is probably paramount to anything else. And similar to what you said, BJ, in palliative care, maybe not so much in palliative care, but in hospice at least, there isn't a fixing element going on. And so the field opens up to all of these possibilities of how can a human being express? How do the people around them express? And it's not so much about interventions and tools, even though they're used and they're certainly helpful, and I'm grateful for them. It's not the primary focus of any engagement that I am interacting in. So that continues to also inspire me. And it deepens me as a human being. I feel more alive when I'm on that threshold of supporting other people to find that threshold for themselves. So that's, yeah, and how I kept staying in, just because it's just kept calling me in, and there's work to be done.
Yeah, well, I think you and I keep chasing each other around a little bit too.
Yeah.
So for the rest of the crew, Ladybird and I met on a meta retreat. I don't know what year that was. But
2008 or
remember?
9? 2008. It was the
Something
year
like
that
that.
Frank had his heart attack. So Frank is out there whenever his first heart attack was.
Right. And I remember falling pretty much immediately in love with you, LB. There was just there's something really sweet about this work. It's really something to meet someone else who does this work one way and another. It's right out of the chutes, you have a lot in common with each other just by virtue of being interested in this subject. I don't know if it's a subject or many subjects, but I guess one thing, like if we look back to when we first met and where we are now, I guess, is there anything, are you surprised by anything? Is it, yeah. Are you surprised by how things have turned out for us individually, or how the field's gone, or any of it?
Yeah, actually, I am surprised that I am so excited about life. I think when I when I met you, certainly, and to everyone else here, I'm just talking to BJ now, but I'm talking to everyone. I had sort of pigeonholed end of life because I was a hospice nurse at that time, and I knew the hospice nurse skills. I knew how to have conversations and offer medications and treat symptom management, and there was this focus on for lack of a better phrase, this phrase of turning towards death, that there was this need to somehow just be like hyper focused on death. And what I feel now is the spaciousness of actually focusing on life, that making space for life allows for death to happen in a way that is more workable or easeful. And so that surprised me. I didn't realize that would be where my focus was going to go. And I'm glad that it has.
Me too.
What about you?
I mean, that's sort of similar. I quickly was very interested in the death thing, just because it's so big, it's so mysterious. But like you, I mean, I think you work in this field for a few minutes, and pretty quickly you come to realize it's really about life. And talking about death is talking about life, and they're so entwined. But I'm happily surprised there was a hunch for me too, that working in this way with others was a way for me to work on myself. Like there's something so beautiful about working on a subject matter that we know that has sort of pan relevance, that it does actually affect every human being that ever was and ever will be. That I'd say I love that our subject is like the least esoteric thing imaginable. Everyone has entrance to this subject. Everyone brings some expertise, and so we get to find ourselves in this work one way and another, which is so cool. It's not like we have our work life and our professional life. I mean, that blurs boundaries and can get a little tricky. I know you and I both dance with that a little bit, but there's something really sweet about the individual and the social, the personal and the professional, and all these things kind of coming together in this work. And that it was, I had a sense that would be the case, but I hadn't quite understood how rich and fulfilling that would be over time. Like, I don't think we'll ever get bored with this work. And there's so many different ways to exercise it.
Was
So
that
I was going to
part
ask,
of your inspiration with Mettle Health? What was part of that inspiration to create that platform?
yeah, I mean, part of the inspiration was a couple different things. One was having worked in the healthcare system from a few different angles, as Susan mentioned. We've always been aware that the healthcare system is this amazing thing, excuse me, but it also has some profound shortcomings. And so so far in my career, a lot of it has been working within healthcare to try to move things a little bit differently and be something of an antidote to so much of the rest of healthcare. And I feel like over time, I've come to the sort of sense that if healthcare is going to improve as a system, a lot of the effort's going to need to come from outside of the system. In other words, if we just leave the healthcare system, leave it up to the healthcare system to change healthcare, I don't know that we're going to get very far. But rather, if we circle out to the public and we see ourselves as human beings first, not just as a doctor or nurse, whatever else, if we work at that level of human to human, and if we take our experience from working within that system outside of the system and sit on the periphery, sit on the edge, overlooking, having a line of sight into that system, but also a line of sight outside of the healthcare system, because medicine, the walls of medicine are very high, and especially in academic centers like UCSF, you can get seduced into thinking that that world is the world. But we know there's all sorts of great stuff going on in the community. So anyway, so part of the impulse was to be to come from that system to but to work outside of it. That gave us a special line of sight. So that was one impulse. A second impulse was just realizing over time where my interests were, and where I felt particularly useful, maybe, was really actually working on the non-medical pieces. As a doctor, it's nice. There's power, if that's the right word, in being a doctor. People, there's a kind of a clear space, and people look to you in ways that you have a running start with people on some level, in some ways. But honestly, I've never been really medical science is interesting to me, but it's never been the driver. It's the human experience that's the driver for me, and the medical piece is just one sliver of it all. So I've always kind of enjoyed. It's been fun to be the non-doctor doctor, but I'm growing up. I don't need to be the non-something. That's okay. I don't need to react against it all the time. But I have found that it's all the non-medical pieces, the spiritual, social, existential components, that if to put words to it, but everything else, which actually is particularly interesting to me, and which seems to be so much the stuff that needs more development. The medical piece, that's pretty far down the road, and medicine gets plenty of attention and has plenty of resources. All the non-medical stuff is so much where the action is and so much where the need is. So that was another impulse. Sorry for a long answer here, LB, but that was, a big impulse, was to develop a service that really focused on the non-medical pieces while having enough experience to not have to abandon the medical piece. We can still speak to it, but I'm not becoming someone's doctor through Mettle Health.
Mm-hmm.
I'm coaching other people to use their doctors wisely. And that's the third thing, I think, is this setting up an apparatus, a machine of some sort that gets off the person. It's not BJ doing BJ stuff. It's bigger than that, and to have the system that naturally complements existing work. We're not competing with other doctors. There's no turf war. There's no, to set up something as few natural enemies per se as possible. That's also very appealing for us, to help people use existing resources wisely rather than to spend time trying to create something wholly new. I think so much of the issues, there's plenty of stuff going on in the world. People just don't know about it, and we're just not linking it up. Mm-hmm. So that's another joy here, is to work in this complementary fashion and to link people to existing resources rather than pretend to make new stuff. So that's much of the reasoning behind it. But I'll throw that back on you. Why have you been interested in working with Mettle?
And Ladybird, yeah. We've had a couple of people just saying they're having a hard time hearing your very soft voice. So.
Okay, is that better? Can you hear me now?
I can hear you okay.
Okay.
There's some people, yeah. So why don't you, and then I'll just
sit closer to the computer. I think for many of the same reasons, the medical part. I mean, I became a nurse just so I could get in the door, because nurses, also like doctors, have sort of an entrance into conversation, and there's a trust built in, an assumption that something is going to happen. And I always felt like it was like a magic trick. Like, while I'm over here, fiddling with the morphine bag, I'm actually trying to have this other conversation. And that was a wonderful way to engage with people. And I increasingly was not as interested in the practical elements of making sure those pieces happened. And rather than be frustrated with myself for not doing them enough or not being engaged enough, I just let myself veer towards this existential element that you're mentioning, that is just full of life and full of, I keep saying potentials and possibility, but I feel like when that is held, then so many other pieces get to happen, and the complexity of what's happening at end of life doesn't go away because I'm not necessarily focusing on what the nurses or doctors are doing. So it felt really freeing. It feels like more people will be impacted, that the field itself will experience a movement of what's actually possible, that the focus isn't just on making sure doctors and nurses and chaplains and social workers know what they're doing or how to do it, that we're really expanding that. And yeah, then the freedom of not being somebody's practitioner where you have to worry about all of those other pieces is also wonderful. I won't deny that.
Yeah.
Yeah.
Well, that's been so much of the joy too. We should throw that on the list of one of the reasons why it's kind of fun to work outside the healthcare system is for our own sake as providers, knowing that burnout sort of comes from the systems issues, is to have the freedom to create a system that has as few impediments, a few things gumming up the work between two human beings as possible. The electronic medical record, the ridiculous 15-minute encounters, all that stuff gets to go away. And the other joy is just having, this is about as pure interactive forum as I think we could create. And that both works well, I think, for our clients, but I think it also works well for us as the providers. And also, like, which is so much of a joy I get of me getting to work with you, LB, is, there's a lot of creative work to be done, and there's a lot of room for style in here. There's a lot of room for individual, our own approach, even though we are all trained in much the same thing and we do much the same work. There's plenty of room for individuation. And one of the joys of me getting to work with you is how creative you are and how you take things deeper with people than most providers I've ever known. And in ways that it's not just deeper, because I don't know what the word is for you, LB, but there's something particular. And I hope all the particulars of you get to shine in this platform. We'll see over time. But, seriously, Shirley, it's such a pleasure.
Well, do you think, so I have a question about that. Thank you for your generosity. I feel the same way. And to speak to the team as well, there's some remarkable people on the Mettle Health team that I'm excited to know that they're out there interacting with people in very different ways than I am or you are. But I'm curious about that. What are these qualities that, with all of the trainings that are out there right now, doula trainings and end of life trainings and how to be present trainings, I've been thinking about this, like, what is it actually that is being trained? What is it that is happening? And what are the qualities that you're speaking to when you talk about what I offer or what you offer or what arises for you? I'm just curious if you can articulate that. I articulate it with a murmuration. Like it feels like starlings that, there's this sort of flow that happens when you are in flow with the person who's dying, and then all kinds of creativity just arises. You don't have to go to a training for that. That person's soul is pulling you and is compelling the work that can happen. And if everyone can pay attention to that, then this beautiful thing gets to happen.
Right on. And that beautiful thing is exquisite and subtle and responsive in ways that certain places where we work or certain systems can sap that energy that allow you to be really present with someone. So in answer to your question, LB, what I see in you and what seems like so precious for the field, because I think one thing that set this up for all of us on this call is hospice and palliative medicine in a lot of ways are, they're growing, and we know that needs to happen. But a lot of the growth, what I see happening compared to when I trained in it, there used to be much more spaciousness and freedom because we were sort of a small, underdeveloped countercultural group within medicine. And so we had sort of free reign as the weirdos to do different things. And especially in the hospital service, I would have we didn't have that many patients. So I could spend 3 hours with a patient in the hospital. Now, thankfully, in a way, the field has concretized and systematized itself in ways that need to happen. and it's gotten more popular, and the censuses are going up. And okay, great. And there's some tension there because, of course, we can't do unique work or extraordinary work if we're whittled down to just another medical specialty with 20 minutes with people, with all these boundaries around it, et cetera. So I am concerned for our field that a lot of that creative juice and spark that a lot of us come to this field with gets whittled away, or there's not space for it. So I think that we have to kind of protect that with each other, for each other.
Mm.
Because when I watch you go in with someone, it's like you're getting in a boat with them. It's not even that you know where that boat's going per se. It's just that you'll be so responsive with people, and there's like a push and a pull. It's not like you come in with an agenda and yanking someone forward. I see you kind of, it's much more mysterious and much more profound how you move with people. Some of it's pushing, some of it's pulling, but either way, you're kind of going around these bends with people, and taking them places where there really aren't words or structures for it otherwise. So anyway, that's what I see. That's what I see you doing. And I think it's, I mean, it'd be interesting to see what your take is on the future, where you'd like to develop yourself or this field further.
Well, I mean, I guess I feel like that's what a lot of us do, right? I mean, without putting words
Mhm.
to it, that's really the role that we have. And ironically, this experience because of COVID and having to go virtually for so many things,
Mhm.
including something like this, which I know, Susan, you would have us out at Mission Hospice, and it would be a whole different experience. But it's shown the possibility that you can actually connect to individuals, to groups, to people through this modality. And this, it, to me, it's taken that control element, it's kind of softened that one more
Mhm.
step. Like, oh yeah, I don't have to be so controlling about
Mhm.
how this is going to happen. Of course, I have preferences. If I look into the future, yeah, I want um, people to be at peace, to be at ease, to not be suffering. I mean, this is something that I don't know who would want suffering. But I am one of those strange people that I don't feel like it's a right to not have suffering. I think it's a
Mhm.
wonderful option, and it's great
Mhm.
when it happens. But I don't want my focus moving forward with the work to be about making everybody have this cookie cutter experience, where our human experience around what we're capable of is whittled down to pleasurable sensations.
Mhm.
That does not feel like an evolved use of spirituality, of medicine, of psychedelics,
Mhm.
of anything really. So if I think into the future, I think this coming on online has actually been a great
Mhm.
practice for kind of reining myself back in a little bit more. Like, okay, stay in my body. Like, what's going on
Mhm.
with me? How can I let people have autonomy in their own experience, trusting that there's a connection, and that, yeah, being in the boat
Mhm.
is enough.
Mhm.
It's not as good as holding a hand. I would say, I will admit to that,
Mhm.
but maybe it is. I mean, maybe we're just not used to that. I have a
Or maybe it's
preference for
just
holding
something,
hands.
right? Or maybe it's just different. Maybe it's not better or worse, but different. And it will be interesting. Hopefully we'll get to offer an in-person version of of this work down post COVID. We'll see. I know you and I both like that idea,
Yeah.
and on some piece of land somewhere, we'll see if we get there together.
Yeah, I mean, I feel like that element of feeling more is really
Mm.
where I hope this movement goes,
Mhm.
where more people are having conversations or feeling comfortable
Mhm.
being with end of life, that it doesn't turn into a judgment or a comparison or a
Mm.
contest. I mean, sometimes honestly, I feel like there's this oversaturation of, learning about end of life and then becoming an expert with end of life, and then everybody needs to be at the bedside, all of us. It's like, no, everybody doesn't have to be at the bedside.
Mhm.
Everyone doesn't have
Mhm.
to be comfortable with death and dying. Even the person dying doesn't need to be
Right on.
comfortable with it. I don't, that sort of narrow focus makes me a little nervous, and actually, frankly, kind of isn't very compelling.
Amen. There's like the tyranny of comfort. I'm with you. Like another thing that shifted over time is, yeah, comfort's great, but I'm just interested in feeling just about anything, and not shaming anything out of my view. I don't know if personally, if we could, I'm not necessarily so sure how much I want to change anything. I mean, but I guess I am interested in turning down the shame piece, the sort of self-loathing aspects that can happen with illness, disability, death, et cetera, where we turn these arrows on ourselves. I suppose that is, I am really interested in upending that. But to your point, like comfort, sure, it's great, but it's not the only thing. And a lot gets lost in the pursuit of comfort. Meaning and growth isn't always comfortable. I don't know, you said something a moment ago about who the heck would want suffering. Well, I wouldn't want suffering, but Lord knows I'd be a much flatter, lamer, I don't know what, pick an adjective person if I hadn't had some real time with suffering, you know? Um, so like this is where I think there's something really powerful, like suffering that just comes our way as being human beings by virtue of the fact that we have an imagination. We can always picture a world better than the one we have, that there's a tension in being a human being, whether you're fortunate or unfortunate, that smacks of some tension, that there's suffering in the nature of being a human being. That's different from the suffering we just can, like the misery we create, the misery we somehow latch on to. I think there's a really important distinction between those. I wouldn't wish a lack of natural suffering on anybody. I would be like sending them to a very boring heap. Um, but I certainly feel different about inventing more suffering, gratuitous suffering. Anyways, riffing on what
I'm
you were
interested
saying.
what everyone is thinking when they hear this
Yeah.
conversation.
Well, yeah,
Actually,
maybe
Yeah,
should we
yeah,
get to the
super.
Q&A?
somebody's put a couple of somebody who you all might know, Michael Fratkin is here with us today.
Oh,
And
hey.
Hello, Fratkin.
for those that don't know, Michael's a wonderful physician in this space as
He's an
well.
all right physician. He's a
Yeah,
mediocre.
okay.
Yeah.
Since it's VJ's talk, okay. Michael will join us. But anyway, Michael, I think he's got a wonderful practice called resolution care that cares for people and basically invented end of life telemedicine long before the pandemic made it imperative. But now I've lost his question here. He says, what are the raw ingredients that invites the kind of flow that these rascals are currently talking about? Who are we in the matter of showing up to this space, and what might we reflect on ourselves to understand how to trust the flow? And I also think for people that are joining this conversation that might be, I would imagine a lot of people have navigated end of life situations with many, many people here, but for those that may not be on the professional end or just there with somebody who's dying, and we're often tasked with these, kind of things that have to happen versus the sort of more relaxed kind of exchange and opening up space. Just this to this question, the raw ingredients, like what is it, do you think, that in a person that really allows for these kinds of exchanges? And how does the provider influence those kinds of conversations or?
It's a big question for a rascal to answer. Let's see. I mean, I guess the first thing that comes to my mind, Michael, is that at least where I try to go is to bring the focus that life has meaning in and of itself. And a lot of times with this work, it's about an individual's life proving that it has meaning. How can I know that I mattered? How can I show that I care? How can I get across to people that I cared about them? And there's all of this work and focus on like kind of funneling your life out of this enormous universe of living. And when life in and of itself has meaning, then a lot of those other things are not as pressing and huge. And then everybody counts. Everybody is a doula. Everyone is capable of being in that experience and that conversation, because we're all living, we're all having that experience. And it's very esoteric, and not everyone is coming from that place. So as a practitioner, I would say holding all of life as sacred to the ability that you can, so that even entering in a room where someone is dying, that recognizing that everything matters. Everything is mattering and nothing is taking precedence over the other thing. And holding that is a very unique place and offers a lot of space for anyone, the grandchild, to come and be with the grandmother who's dying. They didn't need to go to a training to do that. They didn't need special permission. They just needed to have space to be human and live. It's a long answer. Go ahead, PJ.
I love that. I love that. Reminds me of like one of Frank Ostaseski's teachings that has really stuck with me is his admonition to, push away nothing. To your point, like, that's, I think death's charm is that everything goes. It's not 99% of things, it's everything. So everything is welcome in a way. And we get in trouble when we start partitioning and trying to put things in the good camp versus a bad camp and hierarchize things, et cetera. So super with you. And I guess also that another answer to Michael's good question would be, I think what we can do is we can show up, vulnerable ourselves, naked in a way, not pretending to have all the answers, dare to be, real. I suppose by that I mean full, not posture, not project, not try to ram folks into a certain endpoint, but to be open to being surprised, to being moved, to being stymied, to handing the power rein over to the patient, to not hog that mantle. I think these are ways that we can massage a different experience. In a word, I think it is us daring, being, we ask our patients our clients to be vulnerable all the time. We should show them the same respect. And I think that has a sort of magic. It can be scary for us providers, but I think it's invaluable. There's a way to do that. Obviously, we don't want to, our clients, our patients, they need to know that we bring some confidence to this mix, that we're not just making stuff up. But otherwise, I think the most powerful thing we can do to evince this kind of work is, in a word, be vulnerable ourselves, be exposed ourselves.
Beautiful.
There's a question here that I think you may have addressed just now about to describe your views about coaching somebody at end of life, and how do you see this in terms of interdisciplinary work, and then somebody asks about access to services like Mettle Health in terms of cost, and who would have access to this, which is something that comes up so often in this last year. We see how this pandemic has really affected people. Yeah. So thank you.
Right on. Yeah, I'll take that question real quick. I mean, there's a tension for us at Mettle. I mean, one of the, I guess on the list of why we started Mettle was access. I mean, we know that hospice and palliative care, well, hospice is pretty darn well represented, but palliative care less so. There are whole regions in the US that don't have programs. And even existing programs might have put boundaries around the limits around the kind of patients they see or what work they do. Oftentimes I'll see palliative care programs that call themselves palliative care, but they're really just symptomatologists. They're not there to kind of accompany you or find meaning with you or whatever else. So access to this kind of work is lumpy, lumpier than it should be. So another reason to love the path that Michael's group has sort of set out here is this online format allows us to reach people and be reached by people from all over the place. We have a client at Mettle Health from Croatia, for example. It's just, so we get to talk to people, learn from people they would have never otherwise met. So now the tension is for us to hang our shingle, and to circumvent a lot of the healthcare issues that we've been describing meant we were set up a system that's for now anyway, is self-pay. And I need to own that. That was a decision that we're not going to stay there. So right now it is $220 for an hour session. And as we all know, that's out of reach for many people. So far, we've turned away no one at Mettle Health. So if someone says we would like to point, like, money should not get in the way. So we'll slide folks on a sliding scale. And then we're also trying to really carve out a pathway for employers to pay to cover mental health sessions on behalf of their employees as a way to pay for this work. And then eventually, I do think, depending on how how healthcare delivery policy goes, if we really continue down the road of a value basis of care, well, there will be billing mechanisms for us within the insurance, within the payer world. So those are the three ways we're going to proceed, and we can convince ourselves that combined with free offerings. Like tomorrow we have a free webinar, once a month we have a free webinar. which end up being sort of groups therapy sessions to some degree. And we offer 20-minute free encounters and things like that. So this is the way we convince ourselves that we are being as accessible as possible. But I have to own there's some tension in that one way or another. We can't honestly say that we serve everybody. Not yet, anyway.
One of our wonderful social workers posted a question up here, and the question is, are you hopeful that the healthcare system itself could ever incorporate more fully services like mental health, which I think you've just addressed this? Or will these services and connections always be on the outside? I do see these multidimensional patient-centered conversation hospice care. She's a social worker at Mission Hospice, and but she'd love for that model to be able to flow upstream and into all areas of healthcare and serious illness. This model of really being patient-centric and really deeply listening to what people are saying and letting that be the starting point instead of we have these tools and we're going to impose them on you, and then how can you navigate through this kind of a system?
I'm sorry, Susan. Was there a question? Did I miss a question?
So I think the question is, I guess the question is always, is this always going to be something outside of sort of the way health care is currently incentivized?
Yeah.
You know,
LB, were you going to say something?
Yeah, because I mean, when I'm thinking about just that notion of anything being outside, you know, I mean, again, it goes back to perceptions and how we tend to want things in silos, and then everything needs to either be in or out. And, you know, a lot of medicine was created to save lives. I mean, medicine is doing exactly what we asked it to do, was to have science backing it up to keep people alive and in their bodies. And to then all of a sudden say, but wait a minute, you're not covering the spiritual elements of it. You know, where we're shifting what we're asking of medicine. And I think medicine is adjusting, and it's moving forward in ways that are leaps and bounds, you know, from like amputating legs of people, you know, without anything to help them. I mean, we're in a very different place. And we put a lot of expectations on everything being everything. And I don't know that I would want, you know, my surgeon to be the same person as the person I would talk to about end of life. I don't know that that's necessary. And I think that as humans outside of separating themselves from systems just continue to become comfortable with themselves and being alive and the messiness of humanness, everything trickles up, down, and out and around. It's already happening. Those changes are already happening. I think we just tend to see where it's not happening and get really fixated on that. But a lot is happening. There's a lot of change. And I don't expect so many doctors to be able to want to even have this conversation. That's not what their comfort is. And I think if I can somehow change my expectations around how everybody needs to be a palliative care, you know, person, it will shift it for me at least.
I love that. I think there's so much room. There's relief in that statement. Like, no, not everyone. We don't all have to be everything to everybody. You know, we can't. And this points to a more realistic expectation of us in the medical field. And in so many ways, you know, one of the fun things would be for Mettle Health to help decompress that poor healthcare system. And we're asking so much of it. It's now become the church. It's become the family. It's become everything. So I feel for that darn system and those working within it. I guess part of the point of the question is we should, it's useful, I think, to have the grist of responding and reacting to something like the problems in healthcare. But I don't think that's not we don't need to hang our hat on that. I think if we just develop what we consider the best work we can do, and as things move in society, if whether that work is inside the healthcare system or outside the healthcare system, I personally, I'm agnostic. I don't want us to stick in a reactive mode against anything really. So that's one point. And a second point would be another reason to delight in being a little bit outside the healthcare system to the degree we are, for however long that lasts, is, why do we require people to be miserable to receive hospice or palliative care? In a way, we're a little prisoner to pathologizing people. In order for them to qualify to see us, they've got to be in some amount of distress and miserable, right? And in some pathological state. Another joy would be to just to move irrespective of pathology. And, some of our clients have found their way to us and they're not even sick, which to me is beautiful. I mean, I think it's helpful for us we can mobilize with suffering as this thing that we're reacting to, but why limit it? Isn't it possible to actually seek support to optimize your experience or to take you different places, not just because you're miserable so anyway, finding ways to move around pathology and requiring that we pathologize people for them to get our help, I think is another piece of freedom that we're interested in pursuing. And that right now, that means working outside of the medical model to some degree.
Thank you. Somebody's asking a question here about, particularly for this last year with the increased awareness of family members not being able to be present with loved ones at end of life. And I just want to say I'm so grateful that I work at Mission Hospice, where we were able to open up our hospice house within a month or two of the pandemic. I mean, it was open the whole time, but to open it to allow families to come and visit with their loved ones and be with them when they're dying, and to experience those last days of life together still as a family and a unit. And that's been really wonderful. And the question here is about that, with people dying where their family can't be with them and more people are maybe electing to be comfortable at home. Is that your experience? And would you be physically present with people that were your clients at the end of their life if they were dying at home?
So that last question, did I hear you correctly? Like, would we at Mettle Health be able to go to people's homes and be with them on site in person?
Yes.
Right now, we're not set up to do that. But over time, I would like to develop that capacity. If we can grow, I've done a little bit of that sort of in a one-off way, being in the Bay Area, and a lot of our early referrals came from folks locally. So I've done a little bit of that, but honestly, I think for us at this point in our growth, it's better that what we've often done is help get that person enrolled in hospice, and we are sort of in the background online. If it's not us going into that person's homes, we're helping other people get into that person's homes and working through each other that way. Over time, I would love to develop places, places where people can come get care, and a potential and a possibility for us to go to people in person. But right now, that's not what we do. But we do complement with, we do link to people who do that work, doulas, hospice agents, etc. Did that answer the question? I'm talking in circles a little bit.
Yeah,
Okay.
I think it did. And then Connie, who's one of our volunteers, a palliative care nurse, says, are there changes to our professional education, such as the practice of mindfulness movements, such as yoga or other practices? Because acupuncture schools require students to do these practices as part of their education while they're in school. Just curious if that's.
So I'm sorry.
Would you like to support? Do you foresee that would be useful, or I feel like it's almost would be impossible to integrate that into healthcare education, but I'm willing to be surprised.
Oh, I think it's totally possible. And it is happening. What I would love to see more than mindfulness is physical body awareness. I think we've gotten so far removed from the fact that we're in a body, and that there's there's a whole system. There's a lot going on. There's blood that's flowing. There's tissue that's moving. I mean, there's sensations in the body that you can become aware of and have more of a relationship to, and not have it be this sort of strange entity that doctors and nurses do things to, and that you are just kind of continually leaving it to find a place of peace. I'm really interested in bringing into medical studies a relationship to your own body, to like what is actually happening in there, not from a scientific view, but from a hands-on embodied practices like cranial sacral work and different things where you can actually start tuning into capillaries. And I don't know, it's really amazing. I mean, we're in this amazing vehicle that there's a lot going on every single second, and we so don't pay
Mhm.
attention to it. We don't even know until something is hurting that there's actually, bone growing in your body right now. I mean, it's kind of mind-boggling that we don't pay more attention to our bodies. So I think that would actually open up a space for people to feel more comfortable relating with discomfort and pain and loss if there was an actual relationship to the body, not so much spirit, or in addition to spirit, I should say. I wouldn't say
Yeah.
instead of.
We're trying to sort of this mantle of transcending your body or being beyond your body. And I do think I think we know that life is all over the place in us and outside of us. But I am with you, LB. I do think if we're not careful, we, through our intellect or whatever our practices, we end up blowing past this amazing fleshy thing that we are. And it's the thing that's the one thing we know dies, that we, that I'm not sure why we don't honor it more. And for me, the word that I love the most around this is the aesthetic world, the world of the senses. I think that is a powerfully underdeveloped sort of field, an area of study. Why it was very helpful for me to study art as a way into this subject. Because it does get at the body, does get at the senses. Anyway, just to herald what you're saying, I'm with you. And I do think there's room for there's in medical school curriculum. I've been a part of at UCSF. That they revisit that curriculum every so often, and there is palliative care has been driven deeper into the curriculum, but as have integrative medicine modalities. And of course, it's a little, there's like a integrative or complementary alternative medicines, like this wastebasket filled with everything that's not medical. So it's a little, short shrift, but it's a portal. It's a sort of a way in, and it's perfectly reasonable to expect that increasingly our doctors and nurses of tomorrow will have at least been exposed to and therefore have some inborn respect for other modalities. Got a ways to go, but it's not. I don't think that's impossible by any stretch. I'm with you, LB.
Yeah, and I think also letting things evolve. I feel like there's a lot of impatience that an idea comes and we want everyone to be already 100 steps ahead of the process of actually getting there. And I'm excited about what's going to be happening when I'm dead. That people are going to continue to evolve, hopefully, and it will be a really different landscape. But it's not going to probably happen. All of that's not going to happen in my lifetime. And can I be okay with that and still be engaged in what's happening and not always be frustrated with where we're not? And just know that we're still going. We're moving forward. We're moving in a direction. It's changing.
Thank you, Lady Bird. That's beautiful. I'm a New Yorker, so I'm always like the one that's 55,000 steps ahead, and then it's not where anybody else needs to be. So.
Don't get me wrong. I have plenty of complaints.
appreciate
I'm speaking so that I can remind myself. It's not that I'm somehow magically in this place of acceptance. I'm not.
I get that. And Connie is asking, does Mettle Health have something to offer for family medicine, so that family medicine and internal medicine can grow? The primary MD nurse practitioner is shrinking in numbers. Physician suicide rate is at a very high. And I think some of what you're talking about and being inside or outside or no inside or outside, wherever you are in the healthcare system, if you're in the healthcare system, it's a hard place to be, it seems. And so curious about what the future will hold without primary care physicians or nurses too.
It's not a world I'd want to necessarily live in if I had choice. I mean, primary care is absolutely essential and is increasingly treated as inessential. And somehow, the drive for specialization in the medical industry is profound. A lot of good has come from that, but it's come at the expense of the whole. This is the space that palliative care has stepped into. In so many ways that our field is a corrective to where medicine has gone awry. And one way to describe that is it's given up on this sort of whole person view that it was embodied in the family practice doc or the internal medicine doc. So one answer to the question is we certainly value that work deeply. And one of the things, almost every conversation I have with mental health clients, at some point I ask them, do they have a primary care doctor? And if they don't, I'll push them to, that comes up. So in some ways, we're boosters for the idea of primary care at the very least. And then the other thing we do, one of the things that I hope to develop further is, so yeah, our clients right now, most of our clients are actually caregivers. Maybe 65% are, and then the rest are patients per se. But a few are coming to us as providers who are either burning out and need a safe place to digest their own stuff. And that work has been, I've loved those sessions. That I'm very, so anyway, hopefully over time, Mettle Health will be a go-to place for fellow clinicians to get support too. And so it's a little bit related to the question, slightly tangential, but I do hope we get to build that piece of the puzzle out as well.
Thank you so much, PJ. And somebody's asking about working with people that have very strong religious beliefs. How do you support them?
Well, I'll jump in. I think, you know, religion's just fascinating stuff. So, you know, in my experience, you know, so much of this work, how we're trained and what we do is, you know, we go where people are. You know, I don't meet people with the idea of what they should be. My job is to meet them whoever they actually are. You know, and oftentimes that's a person who has a belief system, religious or otherwise. And so right out of the chutes, I mean, that's just an integral and fascinating and important part of how people are made up. So certainly we honor that, and we do not project any particular view on things. I myself am agnostic, which I love. I feel I grew up in an Episcopalian way. I am still a fan of messages around the golden rule and love and forgiveness, etc. So I've had my own religious experiences, but we are neither require our patients, our clients be religious, nor do we are invested in them not being. So we take our cues from them, including their religious beliefs. I will say it's always interesting for me to watch how people who do have a strong faith, how they approach these issues of meaning, of transcendence, of becoming, of death. So I would just simply say I find myself very fascinated with it. And in my experience through Mettle and elsewhere, those who come with a strong belief system, generally, you know, that's a strength. That's to be not just respected, but enjoyed. There's a power in it. The one time where I find that can go sideways is if someone sort of had a lazy faith. You know, they've kind of been recreational churchgoers, or because they grew up in a Catholic, whatever family, that they just say, oh yeah, sure, I believe in God, but it's never been tested. Their faith's never been tested. And so the deathbed is not a great time to have your first test of faith. Very often that can go really spectacularly hard. But now I'm talking in more tangents, so maybe I'll just leave it at that.
No, I think that's really accurate, actually. And I find deep religious faith really fascinating, and I show up with a lot of curiosity and let the person and the family guide me to, like, what is it that they want to share about that, and what are the pieces that are actually providing strength and support and wisdom and a pathway for them. It's quite remarkable. And on the flip side, when there's a lot of fear, I have worked with individuals who were really afraid because of the stories around their faith, around what was going to happen to them or not happen to them. And those are harder places to sit in, because again, you know, you're there with them, and hopefully finding some ways for them to get some support around being with their fear and what that's going to look like for them as much as possible.
I was just going to add one more thing. Just reminded me of what's been coming up with a lot of clients lately is guilt. I think that oftentimes guilt that they couldn't be with a loved one who was at the end of life. But guilt is just coming up strong for me, and regrets are too. And just apropos what you were just saying, LB, you know, sometimes there does seem to need to be a deprogramming. Some folks who are so wrapped up in guilt and so wrapped up that they're being punished per se in their dying. And I guess it's not my role or our role to convince them otherwise per se, but supporting people through to not be flattened by the constructs they grew up with. And I don't know if this may sound off, but sometimes it feels like with our clients, they're sort of unpacking the religious doctrine and getting at their belief in creation and God underneath all the dogma. That has been a really interesting process that can be very powerful for folks. So they get to have their belief, but they can unwind some of the human inventions on top of it that have been holding them down or back. That's a process I've seen happen more and more lately for whatever reason.
VJ and LP. There's a question here about being contracted with hospitals in order to provide care for patients that you see. Does this create barriers? An example I'm thinking about is you know that a specific treatment hasn't been offered to a client or patient, but you think or you know it could be beneficial. How do you convey that message, and is that something that you do?
Well, we have to be, this is where we have to be careful. And there's some different boundaries around this work. As I'm not their physician, we are not their providers. And so we got to be very careful. And of course, we only hear from the client. As we know happens, the doctor may have a very important but different story about what's happening else. So we're just getting one view. So we have to be very careful. But in general, what we do a fair amount of is I wouldn't say, gosh, that doctor should have offered you this. That's asking for trouble, because what do I know? There's often more details than we have access to. But I would say something like, hey, well, next time you see your doctor, it might be helpful if you ask them this, that, or the other thing. Or when your doctor says treatment, for example, they have some treatments for you, ask them what they mean by the word treatment, because a lot of people are laboring under the idea that treatment means something that will cure them. So, for example, a lot of our work would be clarifying terms and coaching them about what to ask or how to hear their doctors. And a little bit different than prescribing something, an important one step removed from prescribing or directing.
One thing I'm thinking about, if you had somebody coming to see you and you felt that end of life, they were engaged kind of in the end of life care of their, I'm just wondering, like, how do you have a conversation with them about hospice, or how would you broach that, or how would you, and also I do see Marvin is here. He's got a question. We're going to come back to that question, Marvin, because we're going to take
Marvin.
to talk about that, but we're going to do a couple of questions that are up here just before that. So curious, like, how would you, and I'm just thinking about so many conversations our outreach team, the nurses on the outreach team have with clients that are being called, they're called to a hospital, and maybe the patient knows what's happening, maybe they don't, maybe the doctor's made a referral, maybe they know that, maybe they don't. But how would you kind of engage with somebody and have a conversation about hospice at end of life with them?
Is the question, how would we with Mettle as on the phone, they're calling us, or just in general in the practice?
I would say if somebody's calling you and you're having kind of a relationship with them, you're seeing them, and it's maybe becomes clearer to you that maybe this is end of life that they're engaged with, but maybe they're not quite there yet, or they're not sure, or they're not sure what to do about that. Just kind of curious in terms of the quality or the types of conversation you would have with them about trying to figure out, is this the right thing for them, or.
Yeah, I mean, it's a really good question because it comes up frequently, and it's probably the hardest place for me, at least, that edge of feeling like I can see something coming, but that's not where that person is with me, or that's not where we're interacting. And so really, again, respecting where they're at and what it is that they're coming to me for. And that's different than what I feel like they need, or what my perspective is. And being very careful about, like, I mean, you can always ask, is it okay if I give you some feedback, or I'm thinking about something, it sounds a little different than what you're sharing with me. How would you feel if I share that with you, before just sort of blurting something out or giving any kind of unsolicited information or advice ever? I can have a lot of opinions about what I think somebody should be doing or not doing, and that's pretty much a guarantee. But to really track myself and get really clear with the person who I'm speaking with, what is it? How can I support you? What is it that you're actually asking? And there might be some other little pegs in the pathway that they want to actually tackle first that has nothing to do with getting onto hospice. and it will actually bring them to hospice without me pushing them to hospice. So it comes back to that subtle listening, that subtle paying attention, that I just keep saying the murmuration, because I'm kind of, other friends have mentioned the murmurations of starlings, and I'm just sort of obsessed with it right now. But it makes so much sense in this work, where there's just there's subtle cues. There's the tone of the voice. There's the way somebody brings a question to you. There's what they talked about the first conversation versus the second conversation. There's so much to pay attention to that it goes far beyond just the words being exchanged. And if the practitioner can respond to that, then you'll dance your way over to hospice when you need to get there.
Yeah, I agree with that, Ladybird. And I mean, I think I will also find myself, I often hear myself suggesting one way and another, like just an informational interview with your local hospice agency, just to dip your toe in, just to see what they can offer. And I'll, always try to remember to explain, just so you know what's available down the road if and when you need it, and just, leave it at that. And also make sure people know that they can sign off a hospice if it doesn't feel right. I mean, those couple points of details often can soften the edges around the hospice moment. But I certainly, but we do point folks to hospice one way or another often. It comes up, but I will also say this: it reminds me that one of the things I love about this work is, versus when I was at UCSF or in a clinical setting, it was not uncommon for people to be referred to us in the clinic at UCSF, but not want to be there. They just showed up because their oncologist told them they should go, and so we had a very different motivation. Whereas someone who reaches out to us in Mettle Health, in a way, is predetermined that they are they're seeking help. They're seeking to learn things that they don't yet know. So there's a different affect, a different attitude, a different vibe, and it makes it in some ways easier for me to drop the H word and to kind of explore with people. They came to us, they're motivated. So there's a pre-selection that happens with our system that is in this way helpful. I think I enjoy it. It makes my job easier, I should say.
Yeah, and actually, BJ, to your point, that opting out of hospice is such a wonderful thing to remind people. I have used that a lot too. It's like, you can come onto hospice and you can come right off of it. I mean, you do not have to stay there. They can come, you can meet them, and then you can never see them again. And that's been very helpful to let people know that they have some freedom and choice around what hospice means once they show up.
Yes, I think letting people know they have that autonomy, and we, in our case, we're not coming in to take over their life, though initially it probably feels like that when everybody's coming out to meet them initially. But, a couple of questions from caregivers. One question is, are you dealing in your practice with people who have dementia? And how do you kind of navigate that space? So that's one question, a caregiver. Then another person is asking, they're asking for kind of tips or information as a caregiver to help a young person with medical disabilities navigate death. Like, what kind of conversations, or where might you start those conversations?
I can jump in on the first one there. I mean, we do have a fair amount of our clients are caregiving to someone who has a diagnosis of some form of dementia, and not an insignificant number of our clients have recently have a diagnosis of early cognitive decline or some early dementia diagnosis, and they're still in the position to remember and to plan accordingly. So we do bump into dementia one way or another. It is I think there's a lot for us to develop further. I mean, some of the work we do is just help people through advanced care planning processes, and and when dementia is a diagnosis, that begs for a slightly a specific approach that I think we could do better on. I do think so. I think we know this is going to come up more and more. And so far, I wouldn't say we have a different approach for people who are dancing with dementia, but it may be that we need to develop one. I think there are a lot of particulars both to living with dementia or living with someone who is living with dementia and caregiving for them. But we know that those pressures are unique and last a long time as a rule. So all I can say for now is we do see folks who are dealing with dementia. We don't have a specific approach per se, but I wouldn't be surprised if we talked again in a year or two if we've really developed something more specific to dementia.
Thanks, BJ. That's wonderful. And
And
I will just put out there, and
there
we're
was a
going to have,
question also about youth. Was that,
yeah,
is
and
there a question?
yes. So this
Mm.
question about dementia for anybody that's navigating that space on the 18th, I think, of this month. On the 18th of this month, we've invited Teepa Snow, who does lots of work about working with people with dementia, and in a very unique way. The work that she does, really putting that person in the center, and the issues that are going wrong are usually the caregiver not knowing how to navigate that space with the person with dementia. So there'll be more coming out about that. But yeah, for younger people, Lady Bird, how would you approach that if you're caring
And the
for a younger
question is
person?
for the caregivers, correct?
Yeah, a good tip for a caregiver to help a young person who has medical disabilities
Mm.
navigate death. What kind of conversations could we have?
Mm. Yeah, well, first, I mean, just feeling the grief around that and the sadness um, of a young person dying. You know, there's a lot there that is in the feeling realm. And young people that I've worked with are not usually as challenged with those conversations as you might expect. And I would probably refer people to the hospices because there are some remarkable skilled clinicians at most hospices who have spent years and years having these conversations with children and with children's families. And so there's support out there. There are professionals who, you know, are just absolutely know how to have these conversations. You don't have to pretend to like create something or figure it out on your own. Um, but for me, the first pathway is the feeling pathway. It's not always where everyone is going to go, so it doesn't always work. But if it does work, just acknowledging the sadness and the grief and the anger and the frustration of what it is that is being faced and allowing that to be a part of the space is helpful, as opposed to trying to let's figure out the right conversation or the right entrance in, or you know what we're going to do to manage the loss of this young person and their grief around their own death. So I don't know if that answers the question, but to really reach out to professional support, like BJ was saying, it's not just so much about Mettle Health's team having all of the answers. It's about putting you back out to the community, that you're surrounded by people who actually are incredibly skilled and talented and available to guide these pathways. And I know when I was at Hospice by the Bay, there were some remarkable clinicians that worked in pediatrics, and I'm imagining they're still there and probably at Mission as well.
Yeah, at Mission Hospice, we don't yet have a pediatric program, but I also just want to put a good word in for the George Mark Center over in San
Yes.
Leandro. That is a remarkable program for children that are dying and their families, to support them and offer respite care for medically fragile kids also. A question about, do you facilitate family therapy or dialogues between the person that's dying and their family or significant other, creating space for them to name gratitude, regrets, love, etc.? Is that part of your practice?
Absolutely. Yeah, I love that. We just had just fresh off a conversation yesterday with a big family that was so beautiful. Yeah, so absolutely we do that. We love that. We have a number of clients who we started with the spouse or the caregiver, and then that grew to, then there was time with just the patient, the person who was actually sick, and then oftentimes that will grow into a family meeting, a big family conversation. Other people get brought into the conversation. Love that work. It's so interesting how a singular situation can look so different and have so many different dynamics depending on which family members in the mix. And that's so yes, we do a lot of that. And then so much of our job really is holding the space, setting a stage for things to happen, not directing what's happening, but almost really we just sort of set a stage and maybe put some bumpers around it and facilitate some basic respectful nonviolent communication and mirroring and reflecting so everyone's feeling heard. But really it's just the joy is creating it's the word I was looking for here, not to say stage again, but like a gallery. It feels like a gallery space, like a good gallery space it doesn't scream for attention, it actually sets up the art to get the attention. And that way, if we're doing our job well, we're not singing and dancing, but we're the gallery allowing for the art to be seen and viewed. And that's so much of what I think of our job as. And that's a lot of fun and
Yeah.
friggin' fascinating. Family dynamics are just wild.
Yeah, and let more of that happen. I can't agree with you more, BJ, about that. Really stepping back and letting what is going to happen. And I love that step back role, that step back role.
Thank you. We have one more question, then we're going to go to Marvin's question. Somebody would like you to explain what mental health means. Why that name?
Yeah. So it came, so you guys haven't met Sonia, my business partner, this, and she's a remarkable person. But Sonia, so we were bouncing around the name is so important. Names matter. And especially we're sort of tuned into the languaging issues palliative care has. It's just, we have all sorts of messaging problems. And so for months we were trying to figure out what to call this. And it just kind of came one day as we were realizing we were trying to name this thing. We were trying to not bestow healing or bestow some foreign skill on somebody, but rather we were there to kind of evince their own powers, evince people, to summon people, their innards. And that kind of, as we were ruminating on that, the word mettle came up. I love that word. Someone that tests their mettle or someone shows their mettle. And so it came up as this inner force. And if our job is to help find it and maybe help unlock it, but not somehow insert mettle into people, rather to find their mettle. That's a different, important distinction. So that word really set up as something that was actually really meaningful about what we were trying to achieve. And plus we just like the sound of it. It's sort of, it harkens to mental health, which we're happy to try to take the taboo or the sting out of mental health. So mental health works just fine for us. Metal, or something cool about the material metal, it sounds fine by me. The only association we don't love so much is meddle, like you're meddling in my health, like MEDDLE. That's the only transliteration that we don't love so much. But otherwise, we just like the sound of it too. It's fun to say.
Thank you so much. Michael Fratkin thought it was about
Yes.
searing guitar solos. The wrong workshop, Mark. That's the wrong workshop, Michael. But I want to go
only
back.
when you're around, buddy.
I want to go back because Marvin poses a question that's really a beautiful question. And Marvin is asking, can you talk about the interchange between creating a compassionate space for those who are sick and dying behind the walls of California's prisons and convincing the community at large that the existence of such a space is in fact necessary to sustain and evolve not just prisoners' collective humanity, but our own collective humanity?
Ooh. Well, for those of you who don't know Marvin much, he's the co-founder of Humane Prison Hospice Project and a remarkable being in his own. So that's for another talk. It's a beautiful question. I'm not sure I'm going to be able to answer it as beautifully without kind of repeating myself, which, I mean, it just sounds so basic and annoying by now, but life has meaning regardless of the life, right? And so again, not separating out who deserves humanity, who doesn't deserve humanity, who deserves to be seen and heard and feel like they mattered. Every living being deserves that, in my mind, in my heart. I'm not going to be able to convince anyone of that, but I would hope that by modeling a respect for life and humanity, that again starts to trickle out into what happens. And for anyone who hasn't seen or heard about prison hospice programs, when prisoners are allowed to access their own humanity and be present for others, it absolutely trickles out in a way that the correctional officers, every single person that is seeing in the realm of that experience is impacted by the humanity. And then they take that home. And when they go home, they take it to their communities. And so, again, Marvin, I mean, I guess it's frustrating because I'm asking for patience, but to trust that the evolution is happening. I mean, my God, we are in such a different world right now. We are in such a different world right now. The fact that I, am a person of color interacting with you, BJ. I mean, you're a white person, right? I mean, 100 years ago, this wouldn't be happening. When I was born, my parents couldn't do that very comfortably. So to trust that, as messy and as horrifying as it can feel right now, it is actually in the process of changing. The fact that we can even contemplate having a hospice program in a prison is that to me. And so to trust in the power of that rippling effect, to trust that each starfish, Marvin shares this beautiful story of somebody standing on the beach and throwing starfish back into the ocean, and somebody else coming up and saying, well, my God, there's hundreds of starfish, why are you bothering? And just throwing that one in matters, right? Well, I made a difference with that one. And go back to that place inside of you where you're making a difference. Each action counts. Very preachy, sorry.
Yeah, beautiful.
It's beautiful. And one of the most, I think, powerful might be, I don't know if that's the right word, day in the last 30 years that I've been in end of life care was the day that the three of us were at San Quentin with the training of prisoners on compassionate end of life care, not expecting that in a year from that time they would be engaged in a pandemic, and the work that had happened in that space really helped them support other prisoners and really dive deep into their own humanity.
Yeah, and I went there. I went to San Quentin on Tuesday to deliver letters. We stayed engaged with the men who graduated from the program every 2 weeks, and the parking lot has been locked for a year, the visitors' parking lot. So, we talk about how we've connected on Zoom and at a distance with masks on. They have had zero connectivity with visitors. The isolation is profound, and so the flip side of trusting that evolution is happening is feeling the profound grief and sadness of the suffering that is happening. I mean, it's real. I can feel it in my body as I'm speaking about it. I'm not shying away from the suffering, but hopefully still taking steps towards life, while holding that space, and that capacity to hold suffering is what we're working towards, right? Not trying to do something with it.
Crystal asks, what is your perspective on palliative care services for other vulnerable populations like the homeless? Is this being done anywhere now? And there's a note here from Connie that in LA, there's a program called Under the Bridges. There's also a hospice for homeless people that in Sacramento, it's a residential hospice for homeless people where they can go and die. And we've been doing some work, though not currently, but we did some work in San Mateo County with some of our homeless. We've cared for homeless patients, both in our hospice house and in their shelters. And there's no place.
At Hospice by the Bay, I remember nurses and social workers going to people in cars, on the street. I mean, there are some remarkable people out there in this world doing incredible service. It's, I think that's something that I like to remember as well, that there's just a lot of people out there doing good things. And that have the capacity to do good things, and some of them went to mindfulness training and some of them didn't. And, it's okay.
And
I am aware. Oh, sorry, Suzanne. I was just gonna say, I wish I remembered the name of this. There's a program that I'm aware of out in Toronto or outside of Toronto where they're really trying to beef up a hospice program for folks who were unhoused. I wish I remembered that name because he was doing really beautiful work. So that's my little contribution to the answer to the question.
Is the name Nahid Dosani?
That may be it.
I didn't know that. Somebody posted it in the comments. The work.
Maybe.
Yeah. I
How
just,
about
and
that?
so the last comment from Mary Mathisen, who is also working at Mission Hospice and
Hi,
is my
Mary.
boss.
Hi, Mary.
So she said here that listening to Ladybird, she's struck by something that's challenged her for years. When prisoners see and experience the care of the dying, the ripple effect can transform much more than their end of life experience. And we've segmented out the end of life experience from healthcare. If medical professionals saw and experienced the care of the dying writ large, might we also not shift much more in healthcare by just them being exposed to that kind of care and heartfulness?
Mhm.
And
I
then
feel very strongly about that.
how would we do
Yeah,
that?
exposure, I suppose, is one. I mean, I think back in the Zen Hospice days, and imagining some future places where we can design, develop, create places for people to come live and die. Um, they always had this part of that dream was to have public art exhibitions and find ways through the architecture or through other programming to pull people into that mix to begin to integrate life and death, which is where I think so much of the action will flow. Is once we kind of come to see those things as related, not at odds, life and death, I think all sorts of things will shift, not just healthcare. So I think to your point, Mary, amen. I mean, healthcare is a piece of this puzzle, a big one, but why stop there? I think this is social, this is cultural, this is human. So wherever humans are, this kind of work can shine. And I do think the answer is simply exposure and more people having these experiences themselves or vicariously through people they care about. It's one of my hopes for the aging population is that we're all going to be a little bit closer to the subject, therefore a little more engaged with it, and therefore a little bit affected by it, and therefore a little kinder, and therefore a little more creative. And I do I keep getting out of bed because I believe, Mary, what you're saying is true, and that we will get to at least touch a little bit of that in our lifetimes.
Beautiful. Well, there's so many comments here. Which I'll send you. I'll send them afterwards. I think we're pretty close to time, and I don't know if you probably
Oh
just need
yeah.
to bounce off of here pretty close. But Lizzie Miles, who actually brought Death Cafe to the United States in
Hmm.
2012, I believe, curious about your perspectives, open notes in hospice and palliative care. Given that reading clinical perspectives of limited prognosis may lead patients to losing hope. Oh, we had this, we presented, we presented this workshop in early January about hope at end of life. And the
Hmm.
recording of it by somebody who's researched it for the better part of a couple of decades is up on our YouTube channel, which you can just find by Mission Hospice YouTube. And the gentleman's name is Dr. David Feldman. But I'm curious about this idea that reading their own notes, the clinical perspectives might limit their hope or that they will lose hope.
Well, I can just jump in a little bit. I mean, I think the idea that it's kind of galling that the notes about me as a patient are somehow unopened to me, the patient, the person, the subject. That I do find that galling. And as a physician who knows the vernacular of healthcare, the shorthand that goes into notes, first of all, notes would be largely unintelligible to a person, but that vernacular can, needs deciphering, decoding. So if we're going to go the way of open notes, which on some level I would certainly advocate for, part of that's going to need to be training clinicians of how to communicate in ways that knowing that their notes would be seen by patients, because they could range from entertaining to terrifying to wholly just inaccessible to people, a bunch of gibberish. And I do think we could do harm with those notes accidentally. So I think there would be a lot of work that need to be done to make that a functional and constructive possibility.
Well, thank you so very much to both of you. I'm just so grateful. There's a comment that was just put up that I feel that would maybe be something that many people may have experienced in the last hour and a half. Who said that she's been feeling just so much burnout recently as a palliative care social worker, and she really needed this conversation. I think this really reminds us about what's most important. And I'm just so grateful to both of you for the work you're doing now, the work that you've done, and I am so looking forward, Lady Bird, to continuing the work that we're doing together with Humane Prison Hospice Project and with Marvin and BJ. I'm sure that you will be back at Mission Hospice again for something in the not too distant future. I hope that both of you will. Um, Thank you so very much, all of you that are here with us today. And just a couple of things to note. There will be a workshop on March 18th about dementia and working with people at end of life with dementia that will be very helpful and also very beautiful. And at the beginning of April, on the 8th, we're co-hosting with Seniors at Home Hospice and Palliative Care 101. And then we'll be following that up 2 weeks later with Barbara Carnes, whose Little Blue Book or God from My Sight is in probably almost every hospice or some version of that. And she'll be doing a conversation with our beloved hospice nurse, Gabby Jimenez, and that will be on the 13th, the 15th of April, tax day. So I look forward to seeing you all again. Thank you to our audience that came from all over the country. It's so wonderful to have you
Thank
here.
you, everyone.
And
Yeah,
just
thank you
so
guys.
grateful, so grateful. And I've learned a lot this afternoon, which is always wonderful. I really appreciate just your
Sorry
grounding.
to not be able to see everyone.
So I'm going to
Yeah.
change that. I'm going to turn off the recording because some people are do not want to be. I'm going to turn off the recording and invite everybody into the gallery view. And if people, I will be here after this ends. I don't know if you both need to go, but
I need to
we're going to
scoot.
stop recording. So thank you all so much for coming today, and I look forward to
Yes.
seeing you
It's nice
soon.
to see all the faces scrolling through, though. It's wonderful.
Thank